This is Becky. We want to welcome everyone back and for our next presentation. And if Paul Miller is on, if he could chat Tina Elliott to identify himself, why we will get him pulled into the panel so that he can present. And so this time I will turn it over to Joyce to introduce our next presentation.
Well, welcome back, everyone. As Becky shared, our next discussion will be a panel on community paramedicine. And as you hear, these programs are all going to look very different to you. And what I encourage you to do, as we've all again coming out of COVID, hopefully, is how do we expand our ability to provide access to care? And community paramedicine, I love it because, again, it's not a silo entity. It is truly, as the name says, it is bringing in the community together, because just not one entity can provide the need for access to care. So I'm excited to introduce to you our panel of participants. We first have Brittany Fortinberry. She just started in this role, I believe, last June. So her role is the mobile integrated healthcare coordinator for the Indiana Department of Homeland Security. Her background is that she's a Navy veteran with a background also as an EMT and public health. And her role is dedicated to setting Indiana up for success with mobile integrated health. Next, we have from Phoenix two participants. First is Nathaniel Metz, who is the president and CEO of Phoenix Paramedic Solutions, a diversified EMS agency operating in the state of Indiana, which provides a variety of healthcare services, including emergency and non-emergency medical transports, addiction and mental health services, occupational health solutions for industrial and commercial clients, and a uniquely tailored community paramedicine program for hospitals and communities. Along with him is Jason Paget. Jason has been working in peer-based recovery support programming and development with Phoenix Paramedic Solutions for going on 4 years. Jason also is a person in long-term recovery himself and is so passionate about the professional development and sustainability of peer services. He currently works part-time and with Phoenix, and just begun a full-time role as the Director of Development for the Lafayette Salvation Army Corps. So congratulations, Jason, on your new role. And then we have Paul Miller from Crawfordsville. In 2014, Chief Paul Miller was appointed to the rank of Division Chief from Lieutenant, where he continues to serve. Chief Miller has previously served as an adjunct instructor for Vincennes University and Ivy Tech College. Additionally, Chief Miller is a featured speaker for many state and national conferences, in addition to collaboratively constructing one of the most advanced community paramedicine programs in the country. And then last but not least on our panel, we have Shane Hardwick from the Indiana Metropolitan Police Department. Shane is a community paramedic with Indianapolis EMS and Tactical Medical with the IMPD SWAT team. This year marks his 30th year serving the community as an EMT. He has held many positions within public safety, but has spent the past 6.5 years serving as a paramedic with the Shalom Project. This is a partnership between Indianapolis EMS, the Indianapolis Metropolitan Police Department, and Shepherd Community Center. So again, even though I just want to put a note out there that Shane is in Indy and not per se in a rural community, the area he serves is more or less like a rural community. So please, I'm just so excited for you to hear how he, as a one-man show, has made the impact he has in his community as well. So at that time, I'm going to turn this over to the panel. And I believe, Brittany, you're going to start us off.
And Joyce, this is Becky. I just want to make sure that you're seeing my screen correctly.
Yes.
Okay. And so I will be advancing the slides for the panel. So just kind of bear with us as they say advance slides. And is Paul Miller on? So
He
keep,
has not joined yet, Becky.
okay, thank you. So if he does join, let me know. Otherwise, we will skip over his slides until he's able to.
We'll
So
bring him in as soon as he joins.
thank you. Thank you. Okay, Brittany.
Hi, everyone. So as everyone introduced me, I'm Brittany Fortinberry. I'm the Mobile Integrated Health Coordinator for the State Fire Marshal. We could advance the slide.
And it is stuck. There we go.
You can go ahead and click to the next one. So for Mobile Integrated Health with Indiana, the EMS section of IDHS is an administrative office for the EMS Commission. Staffing for MIH is the State EMS Director, Craig Kinney, and then the State EMS Medical Director, Dr. Kaufman, was in that position, and now it is to be determined on who is going to fill that position. And then there's me, the Mobile Integrated Health Coordinator. Go ahead and next one. So what is Mobile Integrated Health? It is a patient-centered model of care delivering in patients' home or in mobile environments. This includes teams that can come to the patients as well as use telehealth platforms. Community paramedics can visit patients at their home and assist in the health screenings, vaccinations, treatment, and follow-ups for MIH. That can also include social work, substance abuse resources, and mental health, chronic disease management, and much, much more. Delivering the right care at the right time for the right cost. And that's the best way to describe the program. So some of the benefits among the measured benefits experienced nationally with these programs are decreased emissions to the hospitals, decreased cost of treatment to patients, better integration of EMS into healthcare systems, and increased saving to commercial insurance companies. It also may reduce non-emergency 911 calls, and otherwise that would tie up emergency services. So on April 16, 2021, the EMS Commission has a policy on approval for MIH programs. Approval is more as a registration than a certification. Now, the application and the approval process does not prohibit function of MIH programs in Indiana. It's more to be recognized as an approved program and hopefully be able to have more reimbursement opportunities and grant opportunities with the backing of the state, saying that you are an approved program. Preferences will be given to a program that has community purpose and will be fully integrated with staffing, education, protocols versus performing just a function of mobile integrated healthcare. So what we look for in approved programs is what program is based on their community needs. And that can include hospital dismissal, post-discharge, follow-up, readmission prevention, post-response follow-up for certain emergencies such as diabetic or overdose, diabetic counseling and monitoring, chronic disease management, decreased utilization of EMS by high-frequency patients, substance abuse mitigation and mental illness mitigation, OB newborn management programs, and elderly management programs including falls, immunizations, and vaccination initiatives. So for a lot of the programs that have already been approved, this is a list and how it's laid out for Indiana currently. And so if you can tell that, oh,
Sorry.
you're fine. A lot of programs are further north, and we would really love to see a lot more programs start up on the southern side of Indiana, because there's definitely a lot of rural area and opportunity to help serve and fill in the gaps of different communities. And if you're interested, there's also the approval process is on the MIH website. And it's basically a questionnaire, and I thought I had a link to it, but I guess I forgot that. So if you have questions later about that, I will feel free to answer those after everyone else presents.
I guess I'm up. Hello, everybody. Thanks for coming here, and I appreciate you guys attending a lecture on community paramedicine and mobile integrated healthcare. If we were all in a room together, I'd probably be asking you guys all to raise your hands to see how many of you have heard of these kind of models before. And I'm always interested to see what people think they mean. Because as we stated before, there's a lot of diversity within these programs. And despite there being diversity within what these programs do, really what the common denominator is amongst all of these is using an existing asset within our communities to deliver care in a new way. And it's really a great timing right now within our communities to engage in community paramedicine programs, because we're all suffering from staffing shortages within the healthcare community. And we all know that access to care, particularly in rural communities, is always a challenge. I've always had a heart for rural communities. We've always tried to service rural communities. It's a different kind of medicine whenever you are constantly struggling and fighting for resources and finding ways to deliver care to people in need. And especially with some of the transportation crisis that's occurring right now within our state, our jobs are not getting easier in delivering care in rural communities. Just give you a little bit of idea of how this all started. We actually started our first community paramedicine program in 2013. At the time, we actually didn't call it community paramedicine, even though I was a student of CP and I was integrated with a lot of the national programs that were going on. We actually looked at it as a diversified deployment model for EMS agencies. And as a private organization, we looked at it as a way to diversify our business model and grow the way we delivered care in different communities. And since that time, in our first programs in 2013, our scope and our diversified programs have continued to grow and expand. If you look over there on the right side, that's kind of our footprint of where a lot of our CP programs exist, or some variation of a program that we operate. And we'll get into that here in a little bit. We were and still are an experienced 911 provider in rural communities as well. So again, our passion with rural communities is well stated. It's a challenge. Our team loves challenges, and I believe that CP programs, which were actually originally designed for rural communities, but obviously great reach and impact in urban communities too, is just a really great way to solve some of the biggest problems we have in our communities in delivering healthcare. So if you can move on to the next slide. Just to give you an idea of kind of what our staffing deployment model looks like, we are a little bit diversified, right? So we call EMTs community paramedics. We even have some of our nurses in our program engaged. You know, they kind of get the acronym of community paramedic, which sometimes can be confusing to people, especially in most of the world, because a lot of people don't even quite understand the different leveling degrees of paramedics and EMTs within our own industry, right? We all kind of live in these silos. This kind of gives you an idea of kind of what our staffing model looks like within some of our programs. We do a lot of different trainings, right? So we have a lot of certified recovery specialists. We have community health workers. We have individuals trained in question, persuade, and respond, suicide risk training. We have DOT training, CIT training, youth and adult mental health aid, first aid training. Along with our nurses, we've done training in ADL assessments and HDL assessments. And so really, we strive to get any additional training on top of our EMT or paramedic certifications or licensures or RN licensures that we can find. And really, those trainings kind of came organically as we started developing new programs. Like, for instance, one of our very first programs that we started back in 2013 was actually a deployment model utilizing community paramedics and EMTs and paramedics to assist occupational health providers in mitigating injuries and also reducing their work comp spends. And so one of our very first pilot programs, which is with a major manufacturer in the area, they're very sensitive about their names. So I'm not going to mention who they are on here, unfortunately, because I'm sure even though they're not on this conference, I'll probably get a text message and someone say, well, you're not allowed to use our name. So, but what we started doing for them is we actually started using our EMT skills and our paramedic skills to actually address injury in the workplace. And then that actually developed into doing full-on physicals and immunizations programs and drug screening programs for them. And what we found is actually just in the first year alone, this deployment model actually saved our client close to 46% on their occupational health spend. And so that was a big thing for them, and they kept our program. And since that time, we've expanded now to, I think we're sitting at 18 clients across the region, where we are providing a community paramedic deployment model using EMS agencies to address occupational work injury and also wellness now inside those facilities. We'll talk here in a little bit about how that developed into other programs, including an employer recovery program where our drug screens actually then get passed on to our QRT and our mental health and our addiction specialists to actually allow the individual to stay employed and work on that second chance programs for each of those employers. And so that's kind of how it all got started. Go ahead and go to the next slide. You guys can go ahead to the next one too. Here we go. One of the things, and I'll have Jason speak on it here in a little bit, that kind of organically grew was obviously our, we run a rather large addictions program and mental health and behavioral health program. We run that in 9 counties. And he'll talk a little bit about some of the different grants that we run on and operate under and some of the impact that those have had. But one of the things that have organically happened is just simply following our mission and meeting the need. So some of the things that have happened that we're really proud about is actually during the COVID pandemic. We have a couple of really nice resources in our community for homeless shelters. But during the pandemic, whenever there was a positive test, our health department had to actually close down our homeless shelters, which put a lot of individuals out in the streets in the cold without any resources because of the spread of the possible pandemic. And so one of the things that our team did, and I absolutely love our team because they're very passionate about helping people, is that we identified there were people on the streets who need help. So one of the individuals that were on our team who had actually experienced homelessness in the past through his journey came and said, what do we got to do to help these people? And I said, well, we'll do whatever it takes. And within 5 days from that first comment, we actually had an annex shelter in our community up that was being operated by community paramedics in our area that was able to service our community while doing COVID screening, providing frontline resources, even medical care. And so in 5 days, we had an 8-agency collaboration where we were able to provide a homeless shelter with community paramedic staffing and providing resources. We did that through the entire winter, and then we did it again the following year during the same time period. And actually, we just actually shut down the annex shelter again this iteration just I think a month ago. The other cool thing that has happened is that with our relationship with the local homeless shelter is that we actually run a clinic inside of the homeless shelter. And that clinic is managed by a nurse and then our community paramedics and our EMTs as well. And so not only are we providing clinical services in those areas to these individuals who are in need, but we're actually also providing mental health and addiction services and basically being a resource broker for them as well. The whole point and hope of this is actually to also reduce 911 calls and to save on resources. The address where we house our clinic is actually the highest call volume area in our community. And so what we hope to see is a pretty significant reduction in 911 calls as it pertains to that particular area while providing resources directly to those folks. So with that all being said, there's a ton of stuff that we do every single day. I'm going to pass it on to Jason and let him talk a little bit more about the addiction side and the community engagement side, which is incredibly important with any CP or MIH program. So with that being said, I'd like to introduce Jason Paget.
There we go. Thank you, Nate. Can everyone hear me?
Yes.
Okay, excellent. Well, thank you very much, Nate. And Nate covered some of the logistics around what it looks like for our peer program to operate. What I really want to talk about today is what a win-win it has been to incorporate peers into an EMS and community medicine program. So going back a little bit, oftentimes in my career, some of the things that have been best for me were things I didn't think I wanted. And when we first started this quick response team, I was directing a recovery ministry and team program and freelancing just to build up my portfolio to supervise and help build out this program. And very quickly, what we realized was that we were best off employing the peers under Phoenix Paramedic Solutions because managed care agencies and hospitals were much more comfortable working with peers if they were employed by an agency that was bound by HIPAA. And Becky, I don't know if you can turn my camera on that screen like you had Nate's, because all I'm seeing is black there, but if not, that's fine. So I went to work for Phoenix Paramedic Solutions thinking I was happier as my own boss. And I couldn't have been more wrong. It
Okay.
has been, go ahead,
Jason,
ma'am.
let me
Yes.
stop you there, but is everyone seeing black?
I
Tina?
see the slide
See
that says
the-
news.
I see
Yeah,
this,
we can-
I see new news.
the slide.
I see the slide.
Yeah,
Okay.
And then people's names. And that's okay. That's just a logistical issue. I can talk to a blank screen.
Hmm.
What we found was that it was an absolute win-win for both the EMS agency and the peers. Nate and I were just on a panel 2 days ago with the CRS-CHW conference talking about the professional development of peers and their journey along that lines. I have found that integrating peers with EMTs, paramedics, nurses, people who have been professionally working in healthcare has been instrumental in expediting their professional development. But the flip side has been true as well. A lot of people who work in EMS or first responders are really callous to mental health and substance use issues. And if you're not one of those people, I'm not trying to insult you, but I'm a realist too. And I was a United States Marine and I get the perspective. What peers brought to that was an example of what recovery looks like in a real human being. And I saw a real return of empathy and hope in those first responders and their response to people who are struggling with particularly substance use, as well as mental health. It's also extremely helpful on the sustainability side. So I know the EMS has struggled eternally with Medicaid reimbursement levels, and adding another layer of services like within community paramedicine could help to bolster that. But if you look at right now, there's a ton of money available from the federal government from the opioid settlements, which can be leveraged to get these programs off the ground. If you look historically, back at the cocaine epidemic, which I'm plenty old enough to remember, that money will go away someday. And most of peer support that are out there today are funded by that money. So unless they find a way to actually plug into a reimbursable model that is sustainable and become part of the system, all those will dry up. It happened in the 1980s. There were thousands of peer programs and 501c3s that went out of business when the federal government decided they didn't care about cocaine anymore. So it's a win-win on that front as well. We've also seen it develop an internal wellness program within our company. Nate's big on let's practice what we preach. If we're out there helping other people with second chances and people who are struggling with mental health and substance use, let's make sure that we have at least as robust, if not more, of a program within our organization. And I'll be honest, over the years that I've worked with Phoenix, I've stumbled a little bit and they were right there to support me. And it was paramount in my return to health and recovery. And then finally, it's amazing. Peers, when you walk up to somebody and say, listen, man, I get it. I've been there. I have the same problem or I have a similar problem. Clients or patients are very receptive to that. So peers can be essential in diffusing some of what you may run into with people who are intoxicated on alcohol are just irrational. And I'm not a recovering alcoholic, but nobody can really deal with it very well, whether you're a peer or not. But people who are reluctant to go get help, to go to treatment, who are not completely impaired and are just skeptical of somebody in a uniform, a peer can really help diffuse that and help that person through the stages of change from pre-contemplation into contemplation and even accepting help and moving into action. So that's really where I have seen the win-win, where regardless of how it looks in a daily work environment, the win-win of combining peer supports and EMS is off the charts, in my opinion.
And one of the things, if I could add on, that we identified, and we had a lot of help from Purdue Healthcare Advisors whenever we started developing a lot of these programs and integrating them in. And they did a fantastic project for us where they mapped all of the different resources within our community. And what they did is they mapped them, and then we started developing lines between them and started talking about how we interacted and how we communicated between different resources within our community. And what we found was, and there's tons of statistics on here, the National Council of Behavioral Health has some fantastic statistics on this that show that a lot of the healthcare problems that we face in our community are actually because of the system that they're running in, our own systems of how we provide healthcare. And one of the biggest gaps that we found in our community, and I would dare say that you probably have it in yours too, is the in-between spaces, the spaces between the resources, the space between the hospital and the person's home, the space between the pharmacist and the primary care physician, the space between local EMS and the behavioral health sector, right? And so what we found was that the spaces in between all these resources is where a lot of individuals were falling between the cracks. And there is no more perfect of a mending than a community paramedicine program standing in between all of those spaces and catching individuals and making sure that they're staying connected with the resources and being that glue that sticks between all of the different resources. And what we found whenever we did that in our community were some fantastic outcomes, particularly in the addictions field. We had a massive reduction in overdose deaths. We didn't see a single increase in overdose deaths during the pandemic. We saw a reduction in the uninsured population in our community from 16% down below 10%. And then we also saw drug arrests related to drug charges going from 22% down below 19%. So whenever the community came together and we started dealing with the transitions of care and realizing that a community paramedicine or a mobile integrated healthcare model would be perfectly fit for managing those transitions, we started seeing some pretty fantastic collaboration and outcomes as a result.
Amen.
Again, disrupting the stereotypes. The one thing I would challenge each of you guys to do is to look at your EMS agencies in a different light. Look at them as an ally to care and not just a transport asset. EMS agencies are one of the largest healthcare workforces in the state. All right. But if you look at it from a billing perspective, we're only used for like 7 or 8 different billing codes, right? So if you can engage with us, it can be incredibly impactful. And that's what I would suggest to all of you guys. And you can advance forward there to the end of our slides. I think this might be the last one.
Okay. Paul, are you able to unmute your line now?
I am. Good morning.
Good morning. And you're a little bit on the faint side.
I don't know if there's much I can do to improve that. I'll talk a little bit louder.
Thank you.
All right. So my name's Paul Miller. I'm the division chief with the Crawfordsville Fire Department, and I'm very excited to be here and share with you what we're doing in Crawfordsville, Indiana, and really piloting across Indiana is about changing expectations in care and redeveloping what public safety could be when we're looking at prevention. So with that, you have to look a little bit of what our community looks like. In Crawfordsville, I work for a very small rural fire department, but we have a lot of things that we're very proud of. Our community's traditionally listed as one of the top 100 rural communities to live in. We have rich industry. We're attracting new business and industry through our fire department with non-traditional partnerships. And we have fantastic access to our local politician and elected officials, both on the local and the state level. And we've used that to really leverage relationships to build our community paramedicine project and create a lot of value, both internally and externally. So if we want to jump a few slides, one of the things that we've seen is with our rural health partners and our health system, we saw very extensive gaps in care, and access to care is becoming more and more of a problem. Working with our local health system CEO, we're seeing since 2010, nearly 125 rural health systems have closed and really shifted care to other communities in other areas, which has created a huge burden on our local fire department. Right now, we can see transports many times over an hour, placing our 911 crews out of service for 2.5 hours, which creates many gaps in care for us as a 911 system and our community partners. Many rural health hospitals are operating in the red. And if we see that shift further expand and move our rural health hospitals to larger communities, that's going to have damaging effects. And we want to be a part of partnering to protect one of our largest employers in our community. And changing the conversation is really about economic development. So if we can protect one of our largest employers, and as Governor Holcomb has done, enlisting mobile integrated health as one of his pillar agenda items with healthcare, we can do stuff to attract, like we've done in Crawfordsville, attracting large industry partners, because healthier communities are higher earning communities. And we really have to leverage that opportunity to allow our paramedics to operate as physician extenders. We're seeing many rural communities, especially in the OB, have larger gaps in being able to provide those influential and important services, especially in Indiana, where we're seeing higher infant mortality rates and maternal mortality. So it's really about providing that quadruple aim of care that many of our health specialists speak about, and creating practice transformation for our providers. If we want to jump ahead a few, I think I'm getting ahead of myself. A couple more. So since 2016, we've really been partnering very close with the Indiana State Department of Health to create non-traditional programs in community paramedicine. And the very first one was a heart failure project we partnered with Franciscan Health on. And the first 2 years of that program, starting in a pilot project with just 38 patients to reduce 30-day readmissions to increased incentivized payments for our ACO partners, we saw 0 readmissions. And starting small and building on success, we were able to move to chronic disease management and then high risk OB. Many of these projects centered on 30-day readmission avoidance, but they also incorporated falls prevention to make sure we're allowing our seniors to age in place. Currently, we're one of the only fire departments in the country providing an overdose response that allows us to provide care, medication-assisted treatments in the home, right at the point of crisis, and connecting them with primary care and specialty care. Vaccines and immunizations is a project that we've seen a lot of success in taking the care outside of the hospital and providing it where it's most impactful, right in the patient's home, where you can really look at social determinants that are affecting one's health. I think on the next slide, we talk about, as a firefighter, I don't have a background in healthcare administration, finance, and one of the things that I'm very careful to do is not come into meetings or with any of our community partners and tell them how they could do their job better. One of the things that I think that makes us most successful is we have an ability to sit back and listen when our healthcare administrators are speaking, or any of our community partners when we're going through community needs assessment, and listen to where we can fill in gaps in care, working through our fire department locally to provide value to all of our community partners, whether it's political, public, private, and really create shared value that's going to be impactful. And then we leverage all of our relationships for those partners to be subject matter experts and speak to what their subject matter is, and to really capitalize on trust and credibility and building those non-traditional partnerships. So on the next slide, I was asked to kind of put together some of the hard-hitting questions and things that we've done successfully to construct our projects. And I don't know if that segues into the next one or open for discussion, but that is my high-level elevator presentation to get us to the next steps.
Thank you, Paul.
Yep.
Shane, we'll turn it over to you.
Can you hear me okay?
Yes.
Okay,
Perfect.
great. I echo what Paul says and the rest of the guys. Thank you for having us. We're really excited about the different programs that we do. Although mine is not rural, it is very urban. We suffer with a lot of the same access issues, just for different reasons. So my name is Shane Hardwick. I'm a community paramedic with Indianapolis EMS. In the intro, like you said, February, I started my 30th year in EMS. And for the last 6.5 years, I've been working as a community paramedic. I've been working with it's a joint effort between Indianapolis Emergency Medical Services, Indianapolis Metropolitan Police Department, and the Shepherd Community Center. And this joint effort is called the Shalom Project. Next slide. So shalom means whole peace. And that's exactly what we attempt to do to our neighbors on the Near East side of Indianapolis. It's more than just you sleep well at night. It's more than just you're healthy. It's a whole piece, the holistic being of one. Everything is good and peaceful and healthy within the community. So what's our focus? Our focus is for advocating for our neighbors and navigating them through some of the barriers and obstacles that prevent them from thriving. We do this through partnerships with nearly every hospital and municipal service in the city. So why do we do this, and why is one zip code, which is the 46201 zip code, why is that the primary focus of our efforts? Next slide. Our story begins and ends with Shepherd Community Center. The whole base of our mission is housed, excuse me, I got a kiddo that brought something home to me the other day from the daycare. Our mission is housed out of Shepherd Community Center, which is located on the Near East side of Indianapolis on East Washington Street. Shepherd is a faith-based organization that's been in service to their neighbors for over 35 years. And they're incredible. They have everything, every kind of a service you can imagine, cradle to the grave. They're doing it, and they're doing it exceptionally well. They have pre-K, they have K-5, tax preparation, food pantry, social work, addiction services, the list goes on. And because of that, they have an incredible relationship with the families that they serve within that neighborhood, one of the roughest neighborhoods in the city. In fact, people that live in the 46201 zip code are 300% more likely to be victims of murder, 340% more likely to have a fatal overdose, 400% more likely to be non-fatally shot. There's only 30% home ownership, 35% of the houses are abandoned, 39% are at or below the poverty level. And with all of the crime and overdoses that goes on in that neighborhood, the two number one demographics are single mothers and the elderly. So back in the fall of 2014, at the time, Public Safety Director Troy Riggs came to Shepherd and said, man, we love what you guys are doing within your four walls, but you happen to be located in the middle of one of the most violent zip codes in the Midwest. So what can you do to go out and help your neighbors? So they basically took on, they refer to it as they took on the Catholic mentality of taking on the neighborhood as a parish. They wanted to own the problems that plagued their neighbors in their neighborhood. Next slide. So what'd they do? They went out and found themselves an IMPD officer. This is Officer Adam Perkins. He is a giant of a man, 6'4", 280, shaking his hands like shaking a catcher's mitt. And he's a talker. It takes about 20 minutes for him to tell you what time it is. He was hired to handle quality of life issues, to look after the neighborhood, true in its purest form, beat policing. His only walking orders when he left to go out on the first day on patrol was to go out and be Norm from Cheers. Shepherd and IMPD wanted him to be, everybody to know his name. They didn't want, he was supposed to be this representation of all that is good within public safety. And I think he's done a fantastic job of that. So we quickly found that healthcare related issues were the root of some of these problems. All these in progress calls have been brewing for days, weeks, months, sometimes years, and now it's an emergency. So to note, his salary is 100% paid for through Shepherd Community Center through corporate and private donations. So he is not plucked or plundered for other special projects. He does not have grant money that runs out. He is paid for by Shepherd Community Center. So 6 months in, he's out there on the streets, and knowing that a lot of the quality of life issues was causing the violence and discontent in the neighborhood, and that's what it kind of to be centered around, he figured out, and it's pretty obvious once you get out there and start looking for it, that hunger, housing, and health, what we now look at as social determinants of health, is what was causing a lot of these problems. So they hired me. One of the greatest compliments that my boss gave to me stepping off on this mission 6.5 years ago was, simply put, almost like being Norm from Cheers, but they basically said, we don't know what this looks like. Go out, figure it out, and report back to us what you need. So we didn't have a specific demographic. We didn't have a specific diagnosis to focus on. We were left to build a program that suited our neighborhood. And basically, this is what it looks like. Next slide. And you can go ahead and press play.
Medic 53, 81, 39, Bentley Farms, Lane, difficulty breathing, engine 54. Medic
Shepard posted a job description and I read it, and it was going to give me the opportunity to do police work the way that I think police work should be done.
In the short time you've been around us, I think you're seeing that we know a lot of the people in this neighborhood, people that are coming up to us and that know us and that are more comfortable with us. Starting off by building those relationships and asking, what else can we do for you? How can we help? I think that's a way to start scratching away at the problem.
I don't think I've ever met a police officer and a paramedic that cared so much as these guys did, honestly.
When they respond to a call, it may be a police issue that Adam has to take care of and call for backup from IMPD. But many times there is a healthcare issue and they're not understanding what is available to them, and Shane can route them in that manner.
From about 10 to 2, that's kind of our ideal time to start interacting with folks that we had made contact with the day before, the week before, people that we've been dealing with or interacting with for 6 months. Oh, perfect. Is she over at East? Is she? How's she doing?
Jay always repeats the same comment that poverty restricts people's ability to advocate and navigate.
Your sugar's high, you've got to get that diabetic ulcer figured out. So that's the trip today to the hospital.
This man was staring down the barrel of a full-on amputation. Didn't know how to navigate his insurance, didn't know how to navigate the actual healthcare system, and didn't know how to get a ride to even get to the doctor's office.
Listening and asking more questions is something we're able to do with our time that many of our peers just don't have the opportunity to do.
They took a portion of his heel. He's home now. He's seen his primary care. He actually has a primary care physician now. And last time we checked his blood sugar, it was down about 200 points.
Would we really known all the issues that people are dealing with if Shane and Adam hadn't been in those homes talking to people, if they hadn't had that one-on-one connection? And that's why I said it's important that this is community-driven.
The amount of return trips to the emergency department, the amount of avoidance and readmission to the hospital, I don't even know how you would begin to put a dollar sign on what we've done out here.
It's the relationship that's going to change the game. It's somebody constantly pouring into their lives and them finding hope that things can be different.
We couldn't be more proud. He's been very successful in the fact that he went from calling 911 about once a week to he's called twice in 6 months.
Shepard's always been that constant. That's reassuring to people.
I think by going out and serving the needs that they express to us with no expectations of anything in return, just truly doing it out of the care for their well-being is what will change the quality of life of this neighborhood.
You can go to the next slide. So our program looks a little different because we're actually using, we're kind of reverse engineering what's going on within our society. And we're using quality of life measures and healthcare access to change the overall health of the neighborhood. So the fruits of our labor is this. It's important to point out that this is 30 days before the 911 activity that was done by 5 patients. And the red is 30 days after we got engaged with them. We look at overutilization of 911 as a symptom of an unmet need. And these are not our 5-star players. These are just 5 people that we were engaging when I pulled the numbers. So what we do works. So why are we successful? The answer is easy. We build relationships. We come alongside our neighbors. We guide them, support and encourage. And we do it in their own homes. Like we do it within their neighborhoods. So we do our best to navigate through not only the complexities of the healthcare and legal systems, but the bureaucracy of state, local, and federal governments. It's hard to influence change in someone's behavior if there isn't a relationship to base it off of. So the moment that our neighbors understand we truly care about them, that's the moment that we gain compliance. We're gaining compliance with medication. We're gaining compliance with follow-up primary care appointments, criminal behavior, and the list goes on. What we do isn't transactional. It's not episodic. It's relational, and that's what makes the biggest difference in our program. Thank you for your time.
Thank you both so very much. We have a couple of questions. All these programs are so different. I was wondering if maybe you could just share just a few pieces of information, like how did you start up? If a hospital is sitting out there and they think, wow, I'd love to see this in our community, where do you start?
Paul, you want to field that one?
Yeah, the best place for me, I feel, is the health system. Look for a nursing partner that can carry that through the health system and be that face that can break down a lot of barriers internally in that health organization. Then start bringing along your community partners.
Can I speak to that real quickly?
Sure, go ahead,
So
please.
we've had a lot of success with community collaboration in Lafayette, and I think that the 2 biggest components to plugging into a community collaborative network is either to find an existing one or to create one. But Purdue University, so leveraging your universities is huge because they can do all your data mining. They can keep all your statistics. That they can apply for grants, and they'll do all of it for free, and they're all amazing at it. The other one has been having a non-stakeholder community partner that kind of leads the conversation. And then in Lafayette, that's been the United Way. But when you have a non-stakeholder step up and bring people together, then it's not threatening to anyone. And they firmly believe that they're truly there to better the community rather than to improve their own business.
Shane, what would you suggest? I know you were triggered by a community center, but.
So a lot of that was done before I came along. On the back end, I know that, and this was before social determinants of health was the big buzzword. We knew what we were looking at. We knew what we were looking for. Just at that point, there was what we've done, honestly, is we've kind of built the plane while we were flying it. So I wished I had a clear roadmap, but it is very blurry. We just know what the finish line looks like.
Brittany, do you have any comments to that? I know you're still working your way through this role, and Brittany's role is really we've never had really, I guess, for lack of a better word, a formal structure around these types of programs. And Brittany's been given the task to learn from other states and look at all the best practices and bring it back here to Indiana and put that structure format around us. So I don't know, Brittany, if there's anything maybe you want to share.
So, I mean, of course, definitely work with, try to reach out. I am a great resource to have to be able to help facilitate meetings and stuff with other community paramedicine programs throughout the state. And also, if you just need a guide, looking at the approval program on the MIH website, the format, if you can answer all those questions, then there's no reason that you can't start a program as well. And there's a lot of different major companies definitely trying to help facilitate these programs to come about. Amazon is one of them, Duke Energy, and also a lot of other insurance companies are trying to get involved and stuff. So this is definitely something that is going to be becoming the new normal, especially for Indiana.
And Brittany, could you put your contact information and that website in the chat? We've had that request too. So what I'm hearing is basically, obviously these are all different, but what it all boils down to is entities coming together to bring together collaborations that can occur and to start having those community conversations versus, again, everyone trying to act as a silo. So I appreciate all that. The other question that we have is obviously billable for services. What does that look like? I know that there's been conversations with different bills and so forth, and I know insurance companies, which is very promising, are starting to engage in conversations about how to reimburse for these non-911 for the non-911 transports and just going in the home and doing the follow-up and so forth. And I didn't know what feedback or what you're hearing or what you're seeing in your organizations that you can address that. And Paul, do you want to start? I know just because you talked to me about it and many things, and my eyes do start to glass over, so I can't begin to repeat it, but if maybe you could share what the conversations you've been engaged with.
Yeah, so currently we're not billing, but I saw Nate come unmuted. Nate and I both partnered from different organizations to make sure that legislation was in place to, one, identify community paramedicine, then move forward to the next steps of making this billable and financially sustainable for different health organizations and systems. So while we cannot bill outside of the 911 parameters, Nate and I were very influential in assisting it being able to bill for treat in place, which with everything moving towards a virtual care, it's the start. We can work as physician extenders and be billed under community health worker roles. And then the other thing is when we're really creating practice transformation, working as physician extenders, we can really increase and leverage their RVUs to make the physicians more profitable, to move more patients towards primary care in different health settings and make them more connected with their patients. And we can really help with reducing de-incentivized payments, especially with Medicare Advantage projects coming in place. So there's a lot we can do to partner to create value and cost avoidance. It would look different from CEOs or CFO's perspective. It's not necessarily cost savings because a lot of stuff in the hospital world is billable currently. We're providing better care. Nate?
Yeah, absolutely. This is always one of the, and I mean, I think I started studying real in-depth community paramedicine in like 2010, right? And this has always been a question. And a lot of individuals use it as a question and then they stop, right? And it's a reason not to start a program because there's not a traditional set reimbursement track, although we are moving very, very closely to that in Indiana as well on its way to it. And we had a big win, as Paul talked about over the last couple of sessions. That being said, there are ways to fund these programs. And it talks about how you want to look at them, right? So one of the things that I look at, particularly in rural communities, is look at your local department, look at your local EMS agency. And if you look at, even though volumes are increasing, there's still a lot of downtime that exists within the structure that already lives within your communities, right? And we measure that based off of unit hour utilization. So if your community is already paying for the asset, utilize them in other ways to make an impact, right? That should really be a zero cost effort to use existing resources and downtime to engage a community and provide them care. So that's already a neutral cost issue in a lot of communities right off the bat. The second one is what kind of Paul talked about with cost avoidance. Whenever I first started, I was helping an individual by the name of Gary Wingrove to the Center of Leadership, Innovation, and Research in EMS, develop gap analysis programs that will actually estimate cost savings to hospital systems by initiating community paramedicine programs in particular areas. And whenever we started putting these things through the system, we were finding that hospital systems could save in the hundreds of thousands and even in the millions in communities in general. There was I don't know if it was Shane, but there was a gentleman talking to me about an individual that was in a CP program down in the southern part of the state, in reference to addictions and homelessness. And they were able to get this person treatment and it actually saved the community hundreds of thousands of dollars because of the resources that were being spent on this individual. So providing appropriate care and being proactive is a cost-saving measure for both healthcare systems and communities. On top of that, you can also find creative ways to structure your agreements with individuals. For instance, with us, one of our contracts are actually with the CCBHC, all right? And we are a designated contract operator. So we are almost paid as staffed agency for those individuals to execute the work for them. And so while we do not bill directly for the services, they do. And so there are creative ways to find ways to support these programs. And it's really a matter of whether you want to do it or not to, and how much work you're willing to put into it. And then, of course, part of the reason why our early program started in 2013 with the occupational health side is because we got paid for it. And so it's been self-sustainable since 2013. And that self-sustainable program has actually helped us support other activities as well by diversifying how we're getting paid. I'd also like to point out that one of the more successful organizations in the country is actually Ready Responders, which is a 100% private organization that's specifically for community paramedicine. And I think they surpassed $50 million last year in revenue. And they did so because they contracted directly with payers. All right. They have operations in 6 major cities now, and they're contracted with 6 of the major payers within the United States, where the payers are working with them directly to mitigate expenses. So going to your payers about these programs, you can find some reimbursement through them as well. They're doing that successfully in a couple of other states too. So reimbursement is out there. It doesn't always have to be grant programs. A lot of our programs are running off grants now, but every time we do another year iteration, the biggest question at the end of those grants is how are you going to make this sustainable? So it's something that your program should definitely be looking at.
Thank you, Nate. Brittany, I wasn't sure. I know, again, that you're new to this role. Was there anything you wanted to add? I know you're starting to engage in those conversations.
Yes, so there's a lot of different conversations throughout different insurance companies and stuff. But a lot of it ended when the Delta variant happened and stuff like that. So they're starting to pick up once again, and hopefully by the end of the year, we're going to have a lot more conversations on that this is a reimbursable service and that this is basically the new way of healthcare. So
I'll point out those conversations are happening again through the Rural Health Association. So Amna Anwar and Nicole Watkins through that organization have been organizing for the MCEs around this space, more towards, I think, maternal health, but putting a platform in place since next year is a budget session year that we can have some reimbursements in place.
Thank you. Are there anybody else? Jason, I didn't want to overlook you if you had any further comments on that topic.
No, that's that's Nate's area of expertise, so I'll let him speak to that.
Thank you. Thank you. Yes, and I know, I'm sorry, go ahead.
This is Becky, and I did have a question sent to me through chat. Is there a way to find out, and maybe Nate, you know this, is there a way to find out which payers have already paid for this type of service?
I don't know if there is a direct database for all this. Most of them that I know are from interactions with communities all over the place, right? And like, for instance, I know Humana does it. The reason why I know Humana did it is because our team developed a program for them a couple of years ago called Touchy Healy that they used in Texas. I did not come up with the name. Okay, so I want to reiterate that. I did not come up with the name Touchy Healy, but we did build the program, which was an early diabetic foot ulcer identification program to mitigate amputations, right? And so we developed that within a CP model, and Humana approached us to develop that in partnership with an organization actually in Maryville called Health Call. And so I know they are, I knew United Healthcare is because they're running some programs up in Wisconsin. And so a lot of it has to do, I know Anthem is, even though Anthem's here, and I don't think they're doing it in Indiana yet. They could be. They're doing it in other states as well. So Arizona is another good one to look at. Their whole state Medicaid program is engaged with programs like this too. I hope that Indiana will maybe be like the next Arizona here, maybe in the next year or so, if we keep pushing it. And we've got a lot of rock stars pushing this agenda, so I think it will happen. Brittany may know if there's a database on this. I know our past medical director did a lot of research on this to try to figure out where all these different components were. And that is one of the problems that exist out there, is that how do you identify all these different working agreements that exist out there? But most of the ones that I know are just because I've been engaged in the statewide programs nationally and with these conversations. And I don't know, Brittany, if you have a better guidance to point people towards or not.
So one of the big ones is that, of course, Anthem is starting their own programs throughout the state. So there are 2 programs in Gary, Indiana, and also in Noblesville that they're running and doing a lot of it's for Anthem. And that's the only difference, is that it's not a community-based thing. But there's also just a lot of different people have told me they've gotten reimbursement from the VA that they didn't even bill. So it's one of those things that it's so inconsistent at this moment. There's no way to sit there and say, yes, this is who is doing it, but there's a lot of conversations going in the background about reimbursement and paying for these programs.
And Brittany, are those updates, is your office kind of leading that charge? I don't want to speak for you, and would those updates, if so, like be on your website that you can also share so people can kind of keep abreast of that?
Once we get actual confirmation and true, no miscommunication on this, it will be updated on the website. And also there is going to be an interactive map coming out live in August about everything that's going on in the state in community paramedicine and what programs exist and what they do to help network and facilitate those kind of conversations. And as well as helping with different social work needs, because there is also a lot of components for social networking or social work when it comes to community paramedicine, and trying to ease that. So if someone can't afford to have a social worker currently, to help fill in those gaps until they're able to have their own personal social worker.
Thank you. Does anybody else have any other questions that they've seen?
And Joyce, I wanted to make sure you were aware Shane, his SWAT team had gotten called out.
Yes,
So.
I saw that. Thank you. I know while the others are looking, one I know is going out and visiting the hospitals and talking about, substance use disorder and seeing people in the ER rooms, and then, going through the task of trying to find a place that they can go to for help. And they finally find one, but it's 2 or 3 counties away. So now how do we get them there? I know that, many of your organizations have been the ones that could step in and provide that service. So I think that's just another spoke of it. So what I kind of hear is kind of maybe bringing it together as a recap. If I'm sitting there as a participant of this group, is that one, so how do I start it? It really takes that community organization. But if I'm sitting here as a quality improvement person, how do I step into my community and start those conversations? And so I extend out to the hospitals attending this, that if you need to bring in parties together and you need people here on this panel to also kind of brainstorm, please feel free to reach out to me. That's kind of my task, as working and doing the legwork for you, that you can reach out to me and say, hey, we're interested, not sure where to start, how to start. I'm more than happy to bring all these different, Brittany and the different parties together and people within your community together and start having those conversations. And I would always suggest, another item I would also share is that, you can always start small. You just want to pick one area that you want to focus in, because I know it can be a little overwhelming to think, oh, they do so many things. Start small. What's one thing that you really want to see an improvement on, and capitalizing on that, because as we all know, we have to think outside our 4 walls on how we're really going to address access to care. especially with, the workforce issue and just as we felt in the pandemic when everyone is just overwhelmed by the level of care that's needed. How do we address those that are homebound? How do we address those that are homeless? How do we reach into all those non-traditional populations that need access to care? So I appreciate all that. Are there any last comments that any of the panelists or anyone that has any questions would like to share with us?
Yeah, two things. One, if you're looking for a place to start, one of the things that our community did, and I found it incredibly valuable. I'm very familiar with like team steps and root cause analysis and all those kind of trainings, right, to discover problems. And we went through a program that Purdue University puts on called Strategic Doing. And I've been through root cause analysis and all these trainings before, but the real difference between them is that Strategic Doing is about starting something and moving forward with what you have and not waiting for something or someone or some organization to be in your group that you feel like you absolutely need, because then if that person's not there, then your program doesn't move forward. So it's a really great program and a way to start these conversations is using their mechanisms, because it's about identifying partners who want to try to start this and then figuring out what you can start with the people you have in the room, knowing that as you're successful, that influence will grow. So that's one thing. Look into it. Strategic Doing. Purdue University over at the Purdue Research Park does these for communities with great effect. And then the second thing that I wanted to point out was on that CRS-CHW conversation we had yesterday, Dr. Dupre from FSSA made a comment that I think was really, really fascinating to me. And they were talking about mental health and behavioral health responses in our community. And whenever they reached out to people that are in behavioral health crisis or mental health crisis or addictions, they asked, who would you most prefer to respond to yourself in crisis? Who do you trust the most? And the answer that floated to the top of that ring was actually emergency medical services. It was EMS personnel. So it's just kind of nice to realize that it's a really good place for us to be, and that this type of deployment is actually one of the more trusted types of deployments that our patients see and our communities see. So build on that, I guess, is what I could say.
Jason, did you have any final thoughts? If you don't, that's okay.
My unmute button is sticking today. I just, again, want to reiterate that it really is a win-win to bring peer supports into EMS. And I think that in both fronts, from what I have seen, we really need to make sure that we have clear pathways for people who are coming in at an entry level to move into a more robust career. And I think that cross-training people who are peers as EMTs and paramedics really opens up their career path, and introducing people who are in the EMS world to behavioral health options does the same for them. So embrace one another's industries and build out these community paramedicine models. And I think it definitely is the future.
Oops. I love that. Paul, how about you?
Same issue.
I think you're muted, Paul.
Try this again. I had the same problem Jason did, but I think Jason left everything great. And especially that's a good segue into his next step in career.
And Brittany?
I just want to say, if anyone's interested at all, feel free to reach out to me. I'm willing to travel. I actually love traveling. I'm not from Indiana originally, so me being able to see different parts of the state, I'm willing to do. So if you ever want to meet or just have some questions, feel free to shoot me an email and I will get back to you hopefully within an hour. That's my goal, is to always be responsive.
Okay, well, thank you all. Did the panel, again, one last, I guess, call out, have any other questions that they would like to ask?
Yes, Joyce, I had one last question that was just emailed to me. Is there a website or documentation or change package that could be reviewed to kind of use as a guidance to get started and begin to think about this project?
So I can always help facilitate, and I know Nate and Paul both have a really good resources on that. So I can help facilitate as a state. From the state's perspective, we don't have anything yet, but I can definitely help network and facilitate that.
I don't know, Paul, did you guys, whenever you first started, did you pull out that old how to start a community paramedicine program packet from Eagle County Paramedic Services? That was like, I think it was like published in 2011 or something like that. I think that was one of the first documents I ever read, and I still think it's a pretty damn good one. So there are some packets out there that can help you work through stuff internally that are from other agencies that have started ones or things along those lines. And like I said, reach out to us. There's a plethora of them. And they're all a little bit different, right? Because the communities are different and the programs are a little bit different. So yeah, reach out to us. There's unfortunately, there's not going to be one website that I'm going to point you to where it's going to have listed all of these different resources on them yet. But they are out there. And if you dig around long enough, like, some of us on this panel have, you start to figure out where some of these resources are or the people who you need to talk to. And remember, it's always about finding the smartest person in the room, and it's usually never you. So I always try to reach out to all the people who actually know what they're doing. And through the history of doing that, we've gotten a lot of those contacts. And from my experience, it's all these other great leaders in our country and all these other states. They want to push a new way to care for people, and that passion has always driven them to help others. So there is a huge resource and community out there that once you get engaged with, you can call them up on the telephone, they'll answer your phone call, and they'll walk you through a whole program. So there's a lot of stuff out there, and let us help you.
Because I think, Brittany, what do we have? 20, 25 community paramedicine programs in the state?
We are up to 29 currently that I'm aware of. And we finally have 3 down south that was just announced. They haven't been approved yet, but that is a lot better than where we started when I first started in June. And this is a rapid thing. And just because there's somebody in your county that's covering doesn't mean you can't do a program yourself, because the more help, the better for the communities.
Thank you. I guess I ask one more time. Is there any other questions out there that the panel has received, or anybody else would like to ask? Any hands raised that I'm not seeing?
I see no other questions at this time before we go to our polling question.
Okay. Thank you for the reminder, Becky. Okay, so if not, then we do have a polling question for you, if you don't mind answering to help us. So I think, I don't know, Carolyn or Tina, I'm not sure who's going to put that up. If you want to go ahead and put that up. So if you would just take a few minutes to answer this question.
And the question is, are you interested in learning more about a community paramedicine program? We have a lot of great resources available.
We'll give everybody just a few minutes to answer that. And those of you who are sharing the chat that you are interested, we will be reaching out to you to start those conversations. And so, Becky, I'm not sure if we have, does Tina, are you able to share where we are on those being received and providing the results? Or if not, just let me know.
Tina, are you able to share the results?
I think Carolyn received the instructions on doing that, and I'm not sure if she is ready to share those results.
Okay, we'll give it just a few more minutes to give everybody time.
She said she does not know how to share the results, so I'm
Okay,
sorry.
that's
We can
okay.
share,
No
we can
problem.
share
We
those with
appreciate-
the follow-up email.
Okay, well, thank you so much to everyone on this panel. Oh, there we go. She figured it out. So yes, so we have about 50, looks like 50% of the ones who responded that are interested. So we'll be collecting those and reaching out to you and bringing the appropriate parties to the table, start those conversations. So thank you again, and I'll turn it back over to Becky.
Okay. What we will be doing now is please stay connected. Brent Anderson, the practice coach, will be doing some wellness exercises. We'll begin promptly at 1 o'clock again for the